The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And welcome back to all our listeners. Thanks for joining us again. And also thank you to all our new listeners. Welcome aboard.
Welcome aboard, everybody.
The best way, if you're enjoying our podcast, is to share it with a friend. Then you can talk about it together.
Absolutely. That's how word gets around.
Yeah.
Like all pregnancy stuff, word of mouth.
Oh, my God, it's so word of mouth, isn't it? We know that people choose their care providers, their hospitals, their prams, all based on a friend's recommendation. So if you're really enjoying our podcast, we would appreciate it if you shared it with your friends as well.
All right, today we're talking about the pointy end of labour, the pushing bit.
Yeah, and I'm not going to do salt and pepper.
No.
Push it. That seems to come up every single time someone talks about pushing it.
Yeah, we're above that.
We're above that.
Yeah.
But, it's in the back of my brain there somewhere.
All right.
All right, good. So what we want you to go away with this episode is basically to learn about, well, when does this happen in the labour?
Yeah.
Because some people think that that's all labour's about, but, it's sort of only part of it.
Yeah, that's the TV bit, isn't it?
Yeah,
you
that's
sort
right.
of break your waters in the shops and water goes everywhere and then you're pushing.
The next minute, yeah, pushing. So we want to talk about when that happens in your labour and what to expect. And we've got some tips for pushing.
Nice.
We want you to go away with at least 3 tips to help you in this part of your labour.
Sounds good.
Good. All right, Pat. So I think let's start with what stage of labour is it time to push?
Yeah, it's a surprisingly complex question when you think that would be obvious. The give or take the best time, you've got to be fully dilated. So the cervix has to be fully dilated. But there is some difference of opinion about what should happen after that. It's becoming much more accepted that in the setting of good progress and in the setting of a happy, healthy baby, that you don't start pushing the minute you have a vaginal examination and someone says, oh, you're fully dilated, you should push the baby out now. Because, yeah, the cervix might be fully dilated, but the head might be very high. And it's an awful lot of work to push that head from right up high all the way out. And so a certain amount of time spent in what's called passive descent, waiting for the uterus to push the baby down a fair way down into the pelvis before you start the active pushing, like the deliberate pushing, is a great idea. And one of the main things it's going to help with is how long you have to push for. Bearing in mind that very few people can push forever. It's hard work. And even a very fit athletic person is going to get worn out by the pushing process. And you might get to a point where you just can't manage an effective push anymore. And if the baby's still not out, then we're setting ourselves up for intervention in the form of vacuum or forceps. So it's nice to start pushing when you've got a fighting chance of having the baby all the way out before you get too exhausted.
And it's interesting that you start there because when I was preparing for this podcast, my Google search brought me to a lot of American sites. And in the US, for a lot of hospitals, as soon as someone gets to 10 centimetres, there is the protocol to start getting them to push.
Yeah, it's interesting, isn't it? I think worldwide, you would probably find, I don't know this for a fact, but you would probably find that an early pushing approach is most adopted in the countries that are most at home with intervention. Because you're going to wear some people out if you do that.
Yeah.
Yeah. Whereas if you wait, remember, we're only waiting if it's safe to wait. We're waiting, well mum, well baby, we're going to wait a bit. And if we wait, the ideal amount of time to wait, I think, is is until the point, this might take an hour or more, until the point where the woman can't help but push.
Yeah.
They're the best ones.
Yep.
Okay, and it's a bit gross, but I say to people, it's like doing half a poo, right? Imagine if you were on the toilet and you did half a poo, and someone told you should stop now when it was only half out, right? That would be very difficult to do, right? Yeah. And your body's going to go, I don't think so. I'll just keep going, and that's where you want to get to, where there's an overwhelming, irresistible urge to push.
Yeah, right.
Because I think they're the best ones.
Yeah,
and they require less active coaching because the woman goes, I know I'm supposed to push. I can't help but push.
Yeah.
And they come late in the piece, so that if you save your efforts for those ones, then you're more likely to have the power to push a baby out before something happens that triggers an intervention.
And you might get bragging rights, like I pushed the baby out in 2 pushes.
Yeah, we try and avoid the bragging.
I know.
But
comparisonitis is terrible. Don't listen to how long it takes people to push a baby out.
That comment.
Yes, yeah. I think that is very different information than what I was reading. And in some hospitals, the protocol was, I know that we're going to get into how long is too long to be pushing, but some hospitals were up to 4 hours. They would allow someone to push for 4 hours.
Yeah, I think we suffer from a lack of real evidence here, but I don't think many people could push effectively for 4 hours.
No.
That is an awfully long time to do something as intense as trying to push baby out.
Yeah.
And one point I'm trying to make is we're really talking about people having their first baby here. The pushing phase for second and subsequent babies is often very brief. Sometimes it's kind of absent.
Yeah.
Okay. So that's very different when a baby has come down that path before.
Oh, and I just want to point out that technically this is called second stage, isn't it?
Yeah.
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 Right.
From fully dilated until the baby's out.
I think a lot of people would like to know what is happening to the baby during pushing. Is it more of a stress on the baby during the pushing phase than the contraction phase?
It's a potential stress on the baby just to be coming down the birth canal and just to be, for example, squishing against the cord. Whether or not it makes a difference to the baby's well-being if the woman is actively pushing or not, I don't think so. But there is something physiologically challenging for the baby just to be coming out and just to be being born and just to be fairly squished by that point.
As an obstetrician, can you pick the point when someone's going to push? Like, do they make different facial feet?
Well, 100%. Yeah. So
describe it for us.
Well, experienced people in the birthing space, you can hear it from the corridor.
Yeah.
So there's a change in the pitch of the noise. And somebody 4 or 5 centimetres makes a different noise to somebody who's fully dilated. There's an acute intensity to the discomfort and the pain felt by women at full dilatation that changes the pitch of the noise that they make. And so you can actually hear it before you enter the room.
Yeah, wow.
And that's in particular if it's their second or subsequent baby and it hasn't crept up on them. They've gone from a labour that was just sort of cooking along to suddenly bang straight into the fully dilated, let's push this baby out phase, and they make a different sound.
Yeah.
So that's number one. And then secondly, they will find it nearly impossible to get comfortable. So they'll dance around the bed a bit.
Yeah.
And that's and that is related to the fact that if you've got a head that's about to come out, it is almost technically impossible to be comfortable in the absence of an epidural. So they'll dance around the bed a bit. And then if you see somebody start to push all by themselves without being coached during a painful contraction, which you can sometimes see because if you're watching, the perineum will start to bulge a bit, and you think she's pushing without even anyone coaching.
Yeah.
Terrific sign.
Yeah.
Yeah.
And I want to talk about coaching and spontaneous because, I mean, gosh, that's everywhere. And there's a lot of people that are either foot in either camp. You know, they're like, no coaching should be allowed. Like everybody knows when their body is ready to push. Mm-hmm. And then there's other protocolized coaching.
Yes.
So let's talk about both of those things.
Sure.
So tell me, what does coached pushing mean?
Yeah, I think coached pushing is pretty common. It's pretty common for first timers, pretty common for epidural, because sometimes those people really are ready to push. The head's nicely down, long way down, the cervix is fully dilated, and it really is time to push, but they're not feeling an overwhelming urge to push. Sometimes until right at the end when the head's just about out. So coaching for some people really helps them focus. So painful contraction starts up. We coach the woman to take a big breath in, put her chin down towards her chest, and push firmly down towards her bottom. And you tend to be able to push for about 15 seconds doing that, and then you're out of breath. Quickly let it go, take another breath, and do the same thing again, so that you can get 2 or 3 cycles of that per contraction. So that's the most common sort of form of coached pushing, and some people respond very well to that. Other people don't respond to that at all and actually want to be going internally in their mind into a near meditative or hypnotic state of inner peace in an attempt to remain internally focused and try and disregard the pain. And those people won't tell you they want to be coached out loud, but they might want something as simple as a rub to their lower back or a hold of their hand, and they've got it internally. And
do most people have any idea how that pushing phase, what they might want before then, or do they sort of come up with it and tell you to shut up?
Yeah, well, some people have firm ideas when they're pregnant about how they want that bit to go, but surely you have to have experienced it to really know.
Yeah. And what's your preference? What do you do?
I'm very happy to coach people who want to be coached. And sometimes people politely say, no, I don't need that. I'm going internally here.
Yeah.
And I want you to speak up if you're worried about something. Fine. But I don't mind doing the coaching.
Yeah.
I'm smiling because I had a patient a few years ago whose husband was a coach. He was a motivation coach and a personal trainer, and he was unbelievable. It was just awesome.
Yeah.
Because he had absolutely no shyness about taking over the room and saying, rightio, good, okay, here comes another one, bang, let's go. And the big voice and everything, which sometimes people get funny about. But because that's what he did for a living, to get people off their butt and exercise.
Yeah. And presumably maybe his partner exercised with him and was kind of used to his coaching method or whatever.
Totally fine. Yeah. Well, it worked for them. And I think that's the point. We do what works for people.
Yeah. And I think that is the point, because being militant about whether, as a birth provider, whether someone should be coached or should be having spontaneous pushing, that's sort of not up to them, is it? It's up to the person who's doing the pushing.
Of course. Yeah, of course. We don't know for a fact that coaching works better than non-coaching. So it's not like we've got strong evidence that it helps.
Yeah. You talked about epidural. Can we just flesh that out a little bit?
Yep.
Because that is a bit different, isn't it?
It is. If you've got a really strong epi, you may not get an early urge to push, and in fact, you may not get an urge to push at all, and you may not get an urge to push until the head is like literally half out. So that's a downside of epidurals, is that it might lead the pushing phase to be a bit less efficient. We don't think that necessarily leads to problems, but it can lead to somebody who's fully dilated, the head's very close to out, and they're like, when should I push? So I think that person would really benefit from coach pushing, because we can often, if they're completely pain-free because their epi is very dense, very effective, then we can watch the fetal heart rate monitor, the line that observes the contractions, tell that woman when there's a contraction, and get her to start pushing.
Yeah.
And it's cool to watch, because eventually she'll push because she's been coached to push, but then a point comes where she goes, oh, okay, fine, I can feel that. It's very common for an epidural to actually block all the pain, and eventually the head will come down so far that the pain comes back.
Yeah.
And then she goes, oh, okay, now I know where to push. And that's a good moment, right? Because you know you're close to home.
Yeah.
And speaking of close to home, the other thing that you can see when someone's pushing like a champion is the anus will open and sometimes a bowel motion will come out. And people get super worried that that's going to happen and that they will be embarrassed by that or something. But your caregivers will never be happier than when that happens, because it means that the head's about to come out.
Yeah, there's not room for both.
Yeah, no, that's right. So, and it's not, you're not having a bowel motion in the usual way. What's happening is the baby's head's pushing against the bowel and causing it to open.
Yeah.
And that means you're nearly there.
Yeah. And sometimes you won't even know that that's happened.
No,
like that.
We're pretty discreet about it.
Very discreet. It gets whipped away and there we go.
Yeah.
Ta-da. And can you now describe the different positions that you've seen women get into to push?
Yeah, again, this is a personal preference situation, and there is not, to the best of my knowledge, powerful evidence about what's the best one, but anywhere from on your back to on your back with your legs in the air to on your side to standing up to squatting, they're all a matter of personal preference.
Yeah. One on one knee, one leg extended. Like
Yes.
There's just every variety, whatever, and it's up to the caregiver, to the birth provider,
Yeah.
to manage that, because I would imagine you end up being a bit like an acrobat.
Yes, there, and that. I hope there aren't too many institutions worldwide who are trying to limit this for people. But one of the problems, one of the things we do like to sort of take care of in hospitals is the health and safety of the people who work there.
Yeah.
So what we're looking for, if possible, is, for example, if someone wants to give birth in a squatting position, then we tend to put a bunch of mats around. So not only is the woman standing on a soft mat, but the caregivers can get down on the ground, and help her with easing the head out, supporting the perineum with crowning, and if you're going to do that, then you need to be down there near the ground where the baby's going to come out.
Yeah.
Mm.
Can we talk a little bit about when the head is actually on view and the ring of fire people talk about?
Yeah, so that's a very unpleasant sensation of burning that happens when the skin around the vaginal opening is really stretched as the head crowns up. And what we're kind of looking for at that stage is that the head will crown up slowly, and I always say to people, what we're trying to do here is ease the head out, not blast it out, okay? Blasting the head out is sometimes the result of an irresistible urge to push.
Yeah.
Can't help it, push really hard, bang, head shoots out in one go, and there's a bigger tear. And there's actually quite good evidence that supporting the perineum helps with tearing, so that if we have a obstetric caregiver helping to support that perineal tissue between the vagina and the anus by giving it a little pinch between thumb and fingers, that we can support that tissue and help the head slowly ease out rather than blast out and cause a tear.
So you're pushing all your might, but once you get to that stage, you're breathing your body.
So there's a few techniques there, isn't there? There's the huff and puff method, because it's hard to really push down firmly towards your anus if you haven't closed your glottis, in your throat. So the most effective way to push down, imagine trying to do the world's biggest poo, is we close our glottis, go, and it's hard to do that if you're also going.
Yeah, okay. Right. Yeah.
So the idea is not that the huffing, puffing really does anything. It just stops you pushing so hard.
Radio.
So that is a technique. And the other is just to say, okay, I want you to push, but you got to wind it back. I want show me a 50% push.
Yeah.
Show me a 20% push. Yeah.
And things to expect is the team might have like a warm flannel on your perineum. Yep. Just to help with that tearing as well.
Yeah, that's right at the end.
Yeah. Let's talk about prolonged pushing, because we've talked about pushing a baby out, but we haven't really talked about how long is too long.
Yeah.
And what are the dangers of pushing for too long?
There are some dangers in being fully dilated for too long, but they apply to being fully dilated to very long. So if we look across the developing world today, in 2025, in communities where women don't have access to expert obstetric care, there's still a phenomenon of getting to fully dilated, can't push the baby out, pelvis is narrow, baby's in a bad position, baby's too big, and then without expert intervention, that baby sits there for hours, days, weeks, baby dies, woman develops an obstetric fistula. So the pressure of the head in the pelvis means that blood can't get down to the vaginal and perineal structures, and it might be able to get in under arterial pressure, but it can't get out under venous pressure, and that tissue becomes necrotic, breaks down, and the tissue dies, causing an abnormal tract between the woman's bladder and vagina or bowel and vagina. And this is still a problem in the developing world. In developed countries, the issue is not that. We wouldn't sit around till anything like that happened. The problem is more that we've only got so much pushing power. And that if we've been pushing for so long, it's very likely that they're getting less effective as we go along. And the chances of us getting over the line for an unassisted vaginal birth are going up. The chances of us getting over the line for an unassisted vaginal birth are going down the longer we wait. It's tempting to think, if I wait a bit longer, I'll get there. No, there's a point where you're actually less likely to get there by waiting, because any contractions after that point are quite ineffective. So that's led to this idea of there being time limits at full dilatation. They have to be interpreted with some caution and with flexibility. You might have somebody who's been fully dilated for 3 hours but is still quite obviously pushing extremely well. Well, if the woman's well and the baby's well, can't see the harm and keep going. But you might come in and someone's saying, I cannot push anymore. And so in broad terms, people tend to push pretty well for about 2 hours. And sometimes it's necessary to push for an additional hour if there's an epidural, because of that issue with the epidural taking away some of the urgency to push. So does it mean you freak out and get the forceps out of that when the time limit's up? No. It just means that we move towards a model where we might ease away from doing nothing towards considering doing something. All right? Make some phone calls, make sure there's someone in the room with the expertise to intervene if necessary.
You can talk saying that you've got the ability to sort of make those decisions, but there are some hospitals that are heavily protocolized about time of pushing.
Yes, and I think there are probably hospitals in the developed world where they're very comfortable with intervention.
Yeah. So again, it might be worthwhile just asking that question.
What would happen in this situation?
Yeah.
That scenario that I just described is really one where the baby's well. If we run into a situation where the woman's been pushing for 2.5 hours and now the baby is showing on monitoring the fetal heart rate or listening to the fetal heart rate, that there are distinct decelerations in the fetal heart rate with every contraction that are starting to take a long time to recover, that's a baby that is struggling to manage physiologically with the last bit of the labour. And that's an indication for intervention.
Is there also an indication for intervention because you're trying to prevent prolapse, pelvic organ prolapse then, or future prolapse?
That's a good question. Women who've had prolonged second stages are potentially at higher risk for developing pelvic organ prolapse and needing surgery for that later on. It's a little hard to know sometimes whether the problem with the pelvic floor was created by the prolonged pushing or created by the passage of the large baby.
Yeah.
Chicken or the egg, which actually did the harm. And probably if we look at someone who needs prolapse surgery in their 40s and we look back at their obstetric history, we'll more commonly see things like a baby that came out OP, so looking up instead of down, or a baby that was more than 4.5 kilos, or 1 or 2 babies that required forceps. Those things are more likely to appear in that woman's obstetric history rather than just prolonged second stage.
Yeah. We don't want to put people off pushing.
No.
Now, we promised people 3 of your top tips.
Yep. Far away.
Good. Okay. What's your number 1?
I think that if you are pushing, coached or actively pushing, coached or otherwise, there's I have noticed without formal evidence, this is experience, that a good technique is to wait for the contraction to start and be established. Let it ramp up a little bit. Take a big breath in, put your chin down towards your chest and push firmly down towards your backside.
Yeah, because sometimes you've come home and you've said, yeah, I want to tell people that effective pushing isn't going,
Yeah, so that's true. I mean, you can make as much noise as you want, but if you're making a lot of noise, you can't also be doing that technique.
Oh, I didn't mean about the noise. I meant making the noise as if you're pushing, but actually nothing's actually concentrated down at your belly level.
So just making the noise isn't enough. And in fact, really, really good pushing makes less noise because you're pushing the power down.
Yeah.
With the glottis closed.
Yeah.
Okay. So that's number 1. That is a technique that I've seen time and time again to be quite effective for pushing.
All right. What's your second tip?
That if you're going to have coached pushing, and you want your team, your support people, your partner, whoever's there, as part of that, word them up first. Go to the classes, work out how to do it, and let that person have the confidence to talk you through it, to count them down with you, whatever you want. But work on that support person's confidence to really own that role.
And find out if that person who's pushing thinks that actually she wants something different. She doesn't want a coached pushing stage. Yeah. What does she want?
The person who's doing the coaching needs to be open-minded to the fact that the plan might change.
Yeah.
Okay, so first timer, you don't know exactly how much it's going to hurt. And you might change your mind.
Yeah.
Yeah.
Just don't be a deer in a headlight.
Yeah, well, exactly. Yeah, that's exactly right. So your job is there as a support and encouragement person, and it's important to own that role, step up and do it. Yeah. Even though you're in a weird situation and you're in a hospital and people are around and you feel like you can't have an active role in that situation, the challenge is to do it anyway.
And I reckon one of my tips is with that support person, work on what words of encouragement you want to hear.
Yeah.
So, I mean, not that you ever say this to me, but I can't stand being told I'm a good girl. And, you've done something, good girl. It's like, no.
Yes.
But no.
Yeah, this is a job for a woman.
This is a woman's.
Yeah.
It might be like you're doing so well, you're nearly there, you've got this, gosh, you're strong. Like I can see you working so hard, whatever it is. But work on those words of encouragement together beforehand, because you might just be repeatedly saying something that your partner is saying, would you shut up, in her brain. And she doesn't need that. She needs you to be sort of helping her.
Yeah,
not hindering.
absolutely. Yeah. And then I guess the third one is changing position.
Yep.
So if you've been pushing for a while and it really doesn't feel to you like that is working, like that those pushes are effective, then maybe that they're ineffective, then maybe they are ineffective. Maybe you're really not in a great position. And sometimes we'll see somebody change over to all fours or something like that, and suddenly, bang, it's much better.
Yeah.
They just have more of a knack of automatically, naturally pushing in that different position.
Yeah.
So definitely like that. And then when we're right at the business end and the head's crowning, a tip is being open to perineal support.
Oh, that's 4 tips. Okay, you got 4 tips, people.
Well,
you got a bonus one.
It to 3. Being open to perineal support.
Yep.
Yeah.
Yeah.
There's good evidence that perineal support reduces nasty tears.
Right.
Yeah.
All right, everyone. I hope that's given you enough information to push like
champions.
No one's watching. No, everyone will be watching. No, you've got it. You've got it. You have the ability and the power to push your baby out.
I hope those tips are useful, and some things that I've seen work very well in the past. And thank you for listening. If
you like our information, you want more, we've got our free newsletter. Jump onto our website, which is growmybaby.com.au, and you can sign up for our free newsletter, which just gives you weekly tips. that mirrors your whole pregnancy. Really useful.
Sounds good.
All right. Have a great week. We'll see you next week.
Thanks for listening, everybody.
Bye for now.